In this video, we'll present a case of a patient who had vertebral artery stenosis at the origin that was treated with stenting and balloon angioplasty using the dual ostium balloon. This is a 60-year-old female who presented with subacute symptoms of dizziness and vertigo. Her neurological examination was normal. She had significant past medical history of carcinoma of the tongue that was treated with chemotherapy and radiotherapy several years ago. On imaging, she was found to have left internal carotid artery stenosis as well as left vertebral artery stenosis. Patient had previous carotid artery stenting, and now she presents for stenting of the left vertebral artery. Here is the CTA demonstrating the severe stenosis of the origin, which is the most common site for stenosis of the vertebral artery. Patient was taken to an angiogram. In this angiogram, we demonstrate the severe stenosis of the left vertebral artery. Under conscious sedation, an access was obtained with a 6 French catheter into the left subclavian. Once access was obtained and under full heparinization, you can see the microwire crossing the lesion carefully, not to dislodge any emboli. Once distal access has been obtained, the next step is to bring the stent. In this case, this is a drug-eluting stent to prevent recurrences of the stenosis. We then carefully park the balloon and the stent right at the lesion. We then inject multiple contrast injections to make sure that we have covered the lesion adequately. The balloon is then slowly inflated, and this will deploy the stent. We're holding the guide catheter to make sure that we deploy the stent in the right location. Post-stenting angiogram demonstrates significant improvement of the severe stenosis. The second step of this procedure is to inflate the ostial or the proximal part of the stent with this special ostial dual balloon system. This is a system that has 2 different balloons, one distal and one proximal. First, we make sure that we bring the guide catheter close to the lesion to make it stable. Once we have the catheter close to the stent, we prep the balloon and aspirate multiple times to make sure that we have all the air out of the system. Then we slowly inflate the distal balloon to anchor the system. Once the distal balloon is inflated, the proximal balloon is inflated, making sure that it's not inflated inside of the guide catheter. This is the second balloon proximal to the lesion that is inflating and flaring out the proximal portion of the stent against the subclavian wall. After a few seconds, we then slowly deflate both balloons. Immediate post-stenting and angioplasty angiography demonstrate excellent wall opposition of the stent with opening of the stenosis. Intracranial runs demonstrate no major vessel occlusion, and the procedure is then finished.